the work that we're just launching here at our Center for Addiction Medicine and Policy. And much of it has been truly modeled after and learned from our speaker today. So Dr. Lynch, thank you so much for joining us. Dr. Lynch is our colleague from across the state. He is the medical director of the Pittsburgh Poison Center and the medical director for substance use disorders at the UPMC Health Plan. He's also an emergency medicine attending physician. He did his training at the University of Pittsburgh School of Medicine and his emergency medicine training and his fellowship in medical toxicology there. And he also is boarded in addiction medicine along with medical toxicology and emergency medicine. So thank you so much, Mike, for
That's where I found it.
us on the front end and for joining us today.
Yeah, absolutely. Thank you so much for having me. Yeah, so as Jean Marie talked, I mean, she and I have collaborated quite a bit, especially over the last few years, on a variety of different projects, and in particular discussions around telemedicine, to some extent preceding the pandemic, but obviously, like for all of us, supercharged by the pandemic. So I will present some slides, a little bit of background.
All right, I gotta listen to this meeting.
More about our actual clinic, and then I assume that there will be some questions, and we can have some discussion at the end. That's usually the most fun part for everybody, anyway. So with that, I will share my screen. So I should be able to figure it out a second time.
And anyone else who's not on mute, if you could just put yourself on mute. Thanks. We can see your slides.
There it goes. Okay. So I left in the first kind of intro slides. I think, realistically, these are things that anybody who is joining this call already knows, right? Regarding the overdose epidemic, primarily opioids, of course, not all, other stimulants, a lot of benzos, but still primarily opioids, fentanyl derivatives. The worst year, every year that they collect 12 months of data is the worst 12-month period that there's ever been, unfortunately. The one thing I do point out that I think is important to remember, as the narrative rightly discusses the explosion of the overdose epidemic during the COVID pandemic. That's absolutely true. But we were starting to see, we were starting to see that rise in overdose deaths preceding the pandemic. So the end of 2019 and the beginning of 2020, pre-pandemic. So I think it's important to understand or recognize, and I'm sure many of us do, that after we had thought we were making some gains maybe in 2018, certainly in Pennsylvania, but throughout the country, we started to see the reversal of that tide in 2019 and into the beginning of 2020. And then COVID was like pouring gasoline on that. And then, I'm skipping many steps, but kind of to get to the meat of what we're talking about today and try not to belabor what I think we all know on background, but we all understand as we're treating opioid use disorder, obviously it's a comprehensive treatment approach is going to be the most ideal. Behavioral support, social supports, re-engagement with social resources and behavioral health, mental health treatment and support for co-occurring mental illness. And all of those things are absolutely critical. But medication treatment really is the mainstay of opioid use disorder therapy, ideally combined with as many of those other resources as we possibly can. But without medication treatment, or at least the offer of medication treatment, it's really a disservice to patients. So we know that adherence to methadone or buprenorphine, reduction of up to 50% mortality, or even more in some studies, depending on the medication in the study, reduction in HIV, hepatitis C, improved abstinence rates, reduction in crime, improved social functioning, right? So we often talk about not only preventing bad outcomes, but enhancing health and good outcomes, as well as long-term treatment being associated with some of the correctional neurobiological. Obviously, we understand that in general.
Someone needs to mute. Someone on a phone, 412. Thanks.
Is a chronic disease with no cure, but the medication treatment is absolutely critical. And both the American Society of Addiction Medicine, National Academies of Medicine 2019 report kind of reemphasize that medication treatment. And so if we kind of take that on background, and that, for some of our colleagues maybe who aren't as versed in addiction treatment and OUD treatment, that needs a lot more discussion and unpacking. But I'm kind of going to just establish that as background for us, assuming that we are all on the same page with that. So when we think about medication treatment, one of the things I think that we all recognize has been an issue is getting somebody into that phase where they're actually sitting in front of or talking to the provider that is able to provide those medications. It's a process. Getting into addiction care, there are a lot of things that need to be addressed, a lot of assessments that need to be done in order to make sure that we're providing what patients need to support their individual recovery, understanding that each patient's recovery is going to look and be different. But what we don't want to do is, while we're doing those things, make them wait to access the medication. So I think historically, medication treatment, particularly for opioid use disorder, is almost like the last step. All of those things were happening first to really try to identify the perfect treatment plan and where medications fit in, and then offering access to medication. And I think National Academies and ASAM, more recently in the 2020 practice guideline from ASAM, specifically indicates we probably want to be reversing that. For somebody with an opioid use disorder, particularly if they're in withdrawal or have an urgent need, probably need to have access to those medications first to facilitate those other things happening. We know many patients who seek treatment or identified as potentially benefiting from treatment don't end up engaging and following through with getting into it. And a big part of that is delay in accessing medication. Of course, it's not the only reason, and it's not a cure-all, but I think that's an important barrier. Another barrier is just where can they go to get it? Some of these data are old. I think it's improved since then. More physicians have and providers have X waivers, APPs, and physicians. But among those with an X waiver, especially now with the practice guideline allowing for a 30-patient limit for basically anybody, you don't have to do the extra education. But we also know that most of those providers don't prescribe up to their limits, whether it's 30, 100, or 275. There are still places where, even if there is an X waiver provider, that provider might be very far away, particularly in rural settings, or in urban settings. The provider and the patient may not be very far physically apart, but there are a lot of barriers other than just geography and distance that may inhibit access in a more urban setting, especially for our lower income, lower resourced neighborhoods, where a provider may only be a few blocks away. But I know there are parts, certainly in Pittsburgh, and I suspect in Philadelphia, where the difference of a few blocks can feel like worlds apart for a lot of different reasons. So all of those things provide barriers. I thought there was a good study done looking at a low barrier clinic where they followed patients who essentially called or came in to access care. And if that patient was seen by a provider, an ex-waiver provider, on the same day, they were 7 times more likely to be engaged than if they had to wait 2 or more days for that appointment. So it's just sort of real-world proof that every day that a patient has to wait to access that care, we know we're going to lose more and more of those patients, and hopefully before they come back again. But of course, we know that it is a life-threatening disease, and every missed opportunity could mean the difference between life and death. So these studies are actually pre-pandemic. So even going back a few years, telehealth, as it's slowly begun to become part of our regular medical care environment. And I say slowly because before 2020, rates of utilization were very low throughout most of the U.S., with many providers not offering any telehealth. But even then, we're starting to see studies come out looking at telehealth for delivery of addiction care, and specifically for opioid use disorder care with buprenorphine. So in Maryland and West Virginia, they did studies looking at 3-month retention rates and rates of positive urine drug screen, either compared to sort of a contemporaneous cohort or historical cohorts. And basically what they saw was no significant difference in those patients. Now, of course, they were able to have in-person urine drug screens being done, working with local offices and providers, et cetera, but the actual addiction care was being provided remotely in these cases. And in both of those, they were really looking at rurality as a barrier to accessing care. So there is a foundation of benefit of telehealth for addiction care, or at least feasibility heading into the pandemic. So we can't really talk about addiction care and specifically OUD care for patients using telehealth without discussing the Ryan-Haight Act of 2008. And as many of you probably know, it requires an initial in-person assessment before prescribing a controlled substance. Obviously buprenorphine, benzos, opioids of any kind. And we can understand why this law was necessary, right? In 2008, where were we? We were sort of at the height of the prescription opioid epidemic, where prescriptions were going out. It was obviously being overused. It still sounds weird to say the internet was growing, but this was probably 10 plus years after the explosion of the internet, but more and more people accessing it and using it in different ways. And so trying to ensure that people weren't setting up bogus kind of pharmacies or operations and writing large scripts for controlled substances. So the motivation for the law makes absolute and complete sense. Like things do, they evolved, right? So we're in a different place in 2018 and 2020 than we were in 2008. Those concerns and issues are still there, but the utilization of telehealth has also grown to push up against what some of these barriers and restrictions from Ryan-Haight implemented. Within Ryan-Haight, there were a couple of exceptions for the initial prescribing. So if a patient was in the presence of a DEA licensed provider, but that provider did not have an X waiver in the case of buprenorphine, a remote provider could evaluate that patient for the first time and provide a prescription for buprenorphine or another controlled substance. If the patient was in a DEA registered facility, so even if there wasn't a DEA licensed provider there, but the facility where the patient was, presumably, in a hospital or rehab setting or something like that, where the facility was DEA registered with other support staff, a remote visit could be done and an initial prescription for a controlled substance could be provided. And then finally, patients who had been seen in person at least once by a provider could be provided controlled substance prescriptions thereafter after video or even phone visits. So the Ryan-Haight Act really is about that initial visit, but it required the patient to get to a provider or a place in order to get that care. So we fast forward now to 2020 and the public health emergency, the COVID public health emergency. So in March of 2020, we saw DEA and HHS make a couple of announcements and temporary waivers, which included the Ryan-Haight Act. There were many more related to methadone and take-homes. I mean, there were a lot of things happening to try to ease access to care when we knew that in-person care was going to be limited for some time to come. I don't think any of us foresaw almost 2 years later, we'd still be having peaks and our ERs would be full and crowded out into the waiting rooms, et cetera. But that's where we are now. So in mid-March, DEA permitted telemedicine could be used for initial prescription of controlled substance using an audio-visual visit. And then later in March, DEA actually clarified that audio only for an initial evaluation could be performed to allow for prescribing of buprenorphine. So any controlled substance following an audio-visual visit in mid-March, and then buprenorphine only via audio-only visits as of late March. So in Pennsylvania, Pennsylvania also allowed for that exception. It was due to expire at the end of September, and then the legislature, because of changes in the way that the governor was allowed to manage public health emergencies, the legislature extended that for another 6 months. So coming up in another couple months, we'll have to either have a new law in place or once again extend these temporary waivers while we establish better legislative solutions. So that'll be coming up soon. And then another important part of the access to telehealth for SED. So of course we talk about audio-visual and then audio only. Really important to understand that both low-income as well as rural patients are less likely to have access to either a smartphone or broadband connection, right? So looking at some of these numbers here from Pew, we can see as many as 20% or more of patients wouldn't have access to either broadband or a smartphone. And so asking for people to have an audio-visual evaluation will necessarily discriminate or eliminate that access for the highest risk and highest need individuals in our society. So that audio-only access and or investment into expanding access to broadband and access to technology like smartphones are necessary to make sure that anybody who needs it has access to that care. This was a study looking at primary care and behavioral health visits using phone versus video. And you can see, especially for behavioral health, and within that group would be substance use visits. Nearly 2/3, and this was in California, the visits occurred via telephone and only 14% via video. And I'll show you our data and some other published data showing that to be pretty consistent for addiction care as well. Definitely the large majority required phone-only visits. So that brings us to our telemedicine clinic. So kind of the story, and I don't have slides to take you through it, but the story of this was, as all of this was happening, we're all figuring everything out, right? We can all remember back to March and April of 2020. Everything was changing. Everybody was making plans. We were setting up disaster areas and opening new parts of the hospital, COVID wings, isolation. I mean, in the RER, we're building walls and different units, and all sorts of different things were happening. And clinics were shutting down. Everything was moving to remote. And so during that time, I was speaking with some of the folks from DDAP. The other thing that was getting ready to happen was, I think it was March 18th of 2020, the liquor stores were going to close. So part of the public health emergency and disaster response is they're going to close state-run liquor stores in Pennsylvania. And so we were concerned both, that the emergency departments would see a large influx of patients in alcohol withdrawal, and or that patients wouldn't have anywhere to go because they'd be afraid to go to the EDs, which we know people were very much afraid to go to the EDs at that time. And they wouldn't have anywhere else to go, and there would be a lot of suffering as a result of that in alcohol withdrawal. So the impetus for our bridge program anyway was actually alcohol more than anything else. So through discussions, we were throwing around lots of different options, delivering alcohol, mobile clinics, places, county-run places that could make alcohol available for people, all sorts of different things in addition to accessing care. And so we were building upon, at that time, we were already doing hospital-based telemedicine within UPMC, so emergency department and hospital-based telemedicine. We started doing that a couple of years earlier for buprenorphine inductions and so forth. And so, thinking about now with these waivers, which were just coming out at that time, hey, we can actually deliver this care directly to patients in their homes. With alcohol, we understood it would have to be by video, but hey, if we're doing that, why don't we also make this available for people seeking care for opioid use disorder, because they can't get into their clinics. They're not going to the EDs either. And for that, we can do it through telephone only, at least by the end of March. So we set about trying to set that up. We had never set up an outpatient clinic. I'm a hospital-based, emergency department-based provider. I don't have an outpatient addiction medicine clinic. So we worked with our department to figure out, okay, we need to get patients registered. They may or may not be UPMC patients. So they have to be able to call and get registered into our system. We want to make sure that we have an electronic health record of the visit. Whether it's phone or audio visual, we want to make sure that it's legitimate. It's in our records. So we figure out how to register them. I had to learn how to use Epic because we use Cerner for inpatient and our outpatient is Epic. So our group had to learn how to use Epic and get them scheduled that way. We have VidYO is the audio visual HIPAA compliant platform that we use that is actually part of our Epic. So we had to make sure that that was set up on all of our phones and iPads and computers. To be able to see patients on an outpatient, and how are we going to make sure that they could access that? And if they were doing audio only, what kinds of mechanisms would we have to speak to them over the phone and get information to them, et cetera. So that process all took about a month or so to set up, so that by mid-April, we were able to officially say we can see patients. And then it was a matter of, okay, so who are we going to see? How are we going to market this? Who are we going to tell that this is available? Because we don't already have an existing clinic. It wasn't like we were transitioning a clinic group cohort into telemedicine, which is I think what a lot of people were doing. So we worked with the Department of Drug and Alcohol Programs, did some presentations to the single county authorities. Where I work locally, we spoke to a lot of our treatment provider groups, our harm reduction group, Prevention Point in Pittsburgh, much like you have in Philadelphia, who was running a mobile clinic. About the same time, they were starting up a mobile clinic and saying, hey, we're available to see patients. So they can call that number, which I'll show you later, but call the number and make an appointment and we'll see them. And our goal was to see them the same day. Our initial hours were actually 8 a.m. to 8 p.m. We were Monday through Friday. We weren't sure what kind of volume we would see. We've pared it back a bit because as we've gotten busier, it's actually hard to maintain that, especially without any funding, which we don't have. So that was how we started. And for a long time, we really didn't get much in the way of referrals at all. I'll kind of go here. So you can see, so April, we had one patient on April 27th. A guy from Beaver County with alcohol withdrawal that we managed with alcohol withdrawal and actually onto maintenance treatment. We saw him a few more times. And through December 2020, we made it, I was really getting frustrated. I was like, hey, we went to all this trouble. We made this really cool thing that I think is really impactful. And I was talking to SCAs and I think everybody was very like, who are you? What are you doing? Is this an okay thing to do? We weren't really seeing patients, as you can see, very, very few through the end of December, through the end of 2020. And then starting into January and then February and March, we started seeing more and more referrals coming from single county authorities, treatment providers, harm reduction, mobile clinics, centers of excellence. And as they started referring patients to us, the feedback we were getting is, hey, this worked really well. That patient who called us in really bad withdrawal, we couldn't get them in. So it's something to you guys, and we're getting more of those patients back than we ever have before. So they started sending us more and more patients. The other thing that started happening was patients who did get referred to us, for better or worse, either they couldn't get connected, or they got connected, or they relapsed and then came back a few weeks or a few months later wanting to re-engage. We saw more and more patients more and more times. So the original goal had been to see, patients once, maybe twice, and then hand them off to local care. We're getting more and more patients who are bouncing back to us, either, repeatedly early on to get them established in care, or because we help them out, they get engaged in care, return to using, then re-engage, kind of the normal trajectory of addiction care. And quite frankly, I think probably more and more patients who hear about us by word of mouth, and maybe trying to game the system a little bit, accessing us because we are easy and low barrier. So I think some of that is coming with it as well. And so when we see a patient this way, we do a full addiction and medical history, do all elements, past medical history, social family history, review systems, review the PDMP, which is integrated with our Epic, motivational interviewing. We e-prescribe to their local pharmacy wherever they are. Patients who do meet criteria for opioid use disorder, we will do a home induction for them with buprenorphine. We talk to them. We make written instructions available through a My UPMC app. They create a profile. It's free. It doesn't cost them anything, but I suspect many patients don't do that. I know some do, but most probably don't that way. And it connects to their email. So we also walk them through verbally, how to monitor their own withdrawal, beginning with low dose, and then do a home induction to full maintenance, which for most people is going to be 8 BID. Usually for 7 days, or if they're referred and we know they have a specific set follow-up and fewer or a few more than days or more days than 7, we'll write the prescription to fit their needs. So if it's going to be 9 days, we'll write a 9-day prescription. If it's going to be 4 days, we'll write a 4-day, much like we would from the emergency department. We prescribe naloxone, go over a follow-up plan, make sure that patients have a specific referral to local treatment and or harm reduction. So nobody gets off the phone without either having already established who their local provider is going to be, or us providing it for them, whether it's through the SCA or known treatment programs. And then if they do need to follow back up with us, they are able to do that. We do try to limit it to 3 or 4 calls or a month at most. Although different people with different needs, we take it on a case-by-case basis. So as of yesterday, we have seen 573 unique patients on more than 1,000 visits. 40% are female. Mean age, you can see there, is about 40 with a range of 18 to 74. Of those 573 patients, 22 didn't attend their scheduled visit, so no-show rate of about 3.5%. 87% were audio only, either by choice or by necessity. 82% of our patients were Medicaid or uninsured, about 10% commercial. Oh, I didn't change it. The 6% is Medicare. I didn't adjust my slide. Sorry about that. But you can see nearly 2/3 are Medicaid, and then the next largest cohort are uninsured or self-pay. I went through manually with the PDMP to look at prescription fills. And so of the patients we saw for opioid use disorder, the first 192 that we actually engaged with, 96% filled a prescription for buprenorphine, and 77% filled 2 or more. So as a surrogate marker of some ongoing engagement. I don't have access to all their records, and people are from all over the state, so I don't have an ability to see medical records, and particularly with privacy laws. If they aren't within our system in certain clinics, I can't see them. So I wasn't able to do that. I'm going to work with our Medicaid folks to look at claims data as a follow-up now that we'll have up to 6 months of data for a growing cohort of patients. There was not a significant difference between audio only and audio visual visits. You do see a bit of a trend, a widening of the 2 lines for 2 or more visits. But statistically, it was not significant. So that sort of engagement and retention rate compares pretty favorably, I think, to typical new starts for opioid use disorder care in the published literature. I also, we took, based on some zip code data and things, we looked at the area deprivation and social vulnerability indices of the patients we were caring for relative to UPMC health plan patients because we had more data for them. And really what this is showing is that looking at some of our most vulnerable health plan populations from a social vulnerability standpoint, the patients that were seen in the Bridge Clinic were a very, very high need population, even compared to patients with severe persistent mental illness and plus SCD, which are historically sort of the most vulnerable. The patients we were seeing were really high vulnerability, so probably limited access to care in any other way. And that's consistent with anecdotally, those 550 patients. I personally probably saw about 500 of them. So I can say these are patients that really had very few options and few other places to turn at the time that they got to us. You can see our referral patterns. Most of our referrals came from addiction treatment providers. About a third came from our harm reduction organization and their mobile clinic. County drug and alcohol commissions, close to 10%. Word of mouth. So, my friend used you guys and, I want to get started in treatment, that kind of thing, or unknown or not reported. You can see 29 of those patients were recently released from incarceration, which I think is another obviously high need vulnerable population that needs low barrier access to care. And 7 of our patients were pregnant or immediately postpartum, which again is another sort of high risk group that has trouble accessing care. And some of the reasons that we would see patients is that nobody else would be willing to care for them because they were pregnant. So we would help them get connected to care and get onto treatment. A group including some Jean Marie and Usha Khatri, and then some others who we've worked with from New York, Rhode Island, San Francisco, and in your program at Penn. Recently published data that's actually, it's amazing and it's reassuring, I think, that it's very consistent and I think very similar. This was from a time period earlier in the pandemic, so the first few months, you all, and including the groups in New York and Rhode Island and San Francisco, saw a lot more patients early on than we did. I presume through more public notification as well as existing sort of established clinics and treatment programs. And a lot of the outcomes looked fairly similar. So, mostly audio for that cohort, it was 60% versus 40% with audio visual. 83% engagement within, or return visits within 30 days. Mostly Medicaid with a cohort of uninsured, actually a small cohort of uninsured relative to ours. And then age and gender distribution looks pretty similar as well. So these same kinds of concepts, and you can see here, 3 of the programs were really focusing on a bridging mechanism to transition to alternative care. And so that was also what we have focused on, was not providing long-term care. I think trying to provide long-term care via telemedicine gets more and more challenging the longer into treatment you get, with more and more uncertainty, and probably relative to traditional care, the quality, I think, may suffer depending on what other programs and resources are made available to the patient. But for early and rapid access to care, I think it offers a really important resource. But some of the challenges that we've run into, of course, we can't get urine drug screens. That doesn't bother me too much for initiation. Most patients who are looking for buprenorphine treatment, of course, there are going to be some who are gaming the system. They're looking to get it to divert it or to sell it and those kinds of things. That's true in in-person clinics. It's true in the emergency department. It's true for non-addiction care, I know in the EDs and so forth. So not being able to collect a drug screen, we do a pretty thorough evaluation of the patient. I think the number of patients who would, we would change our management based on the drug screen are relatively low um, for initial care. Ongoing care and surveillance and really keeping a close eye on, are people adherent to treatment and/or are they using over and above treatment or diverting and those kinds of things. It doesn't necessarily, wouldn't change whether or not I would treat the patient, but of course it would change my approach and how successful that patient is in treatment. So, every visit after the first one, I get less and less comfortable without being able to do a bit more surveillance of the patient. Identity theft. I will say we've had a couple of patients now. I think 3 that I can think of those, 573, where we become aware that it was likely a case of identity theft, either because the things weren't matching up, or we would identify the patient, the real individual would realize that prescriptions are being filled under their name and it wasn't them. That unfortunately also is the kind of thing that can happen, I think, in person or remotely. It's maybe, certainly would be concerning that it would be more likely to happen remotely. And this isn't like people can just call and give a fake name and then walk away with buprenorphine. I mean, this really takes committing healthcare fraud on their part, because they do register in our electronic health record in our system. We compare it, we match them to their health coverage when they have it, and then they go to a pharmacy and fill a prescription. And so they have dates of birth, they have Social Security and other information for the patients in order to get registered. So these are true identity theft scenarios, but that's a problem and something that we're working to try to minimize as much as possible. Repeated visits without local engagement, that was never our goal and remains not our goal. And we struggle, if somebody keeps coming back to us, we want them to be getting into local treatment, in person or telehealth. We want the full comprehensive engagement of, established substance use treatment program. But if they keep coming back to us, it's also hard to cut them off and say, no, we're not going to treat you anymore, because we know that it's very hard for some patients to get that established care, either because of their own disorganization, challenges with transportation, childcare, their work, requirements of the programs. And I know some programs around here are scheduling weeks out, so even if they are engaged in doing all the right things, it could be weeks before they actually see a prescribing provider. And then depending on their insurance status or uninsured status. So it becomes tricky, because we don't want to leave people without care or start them and then drop them inappropriately. So we are continuing to work with some of our addiction medicine folks and peer recovery specialist case managers to do as much as we can to provide additional wraparound care and really connect these people with local resources, so that they can continue in their recovery journey, but without kind of continually coming back to the bridge clinic, which is not what it is all designed for. And then sustainability is another challenge, because the reimbursement, as I'm sure you all are aware, is not great. The whole mission is to be available, urgently available for patients within the same day. We want to expand to weekend hours and expand into later hours again on weekdays and things like that. But there's a reason that most clinics are scheduling out a week or even weeks out, is because for reimbursement to be sustainable, you have to have a nearly full schedule. So to have that time available to see people nearly on demand, that's problematic. So staffing it as we've gotten busier has actually gotten more difficult, because we have to dedicate the time. But I think right now our average reimbursement for a visit is like $54 or something like that. And so we're trying to identify funding to help build out those services and continue to be available for patients when they need us. So that's something we're continuing to work on with the state, with counties, with payers, and with our hospitals. So my conclusions from our experience, telemedicine treatment, audio only and audio visual of opioid use disorder in particular. We've had some alcohol, but still about 90+% of our patients are opioid use disorder patients. Is effective in engaging patients. And we serve, I think, a particularly vulnerable population. When you look at the uninsured Medicaid population, and then looking at the vulnerability indices that we have access to. Most of our patients are evaluated via audio only. There's a body of evidence out there for why that may be. In addition to technology accessibility, I think part of it is just people are more comfortable on the phone. There is some body of evidence that people are maybe more likely to be honest and feel comfortable getting into some of their history when they can do it a little bit more disconnected or doing it by audio. The flip side of that, of course, is that the personal connection is really critical, I think, to long-term behavioral health and addiction care, and that part is lost. But I do think, especially for short-term audio-only services, are beneficial to patients. And most of them are Medicaid or self-pay. So ensuring that CMS and Medicaid continue to make these kinds of services accessible, and for self-pay patients or uninsured patients to make sure that they are there's subsidized care to offer to them, as well as coupon programs and things like that for filling medications. We work with some of our local providers in our county, but quite frankly, I don't have those relationships everywhere throughout the state. So it looks a little bit different every single time, and we try to connect with county-based services to help those without insurance. So looking ahead, the disaster declarations are going to run out. We want to make sure we advocate for legislation that will allow at least some degree of ongoing telehealth, ideally audio only as well. Probably there's going to be some guardrails on duration and ensuring that we are trying to engage patients with comprehensive care and not try to replace traditional addiction care with telehealth. I don't think that should be the goal. Making sure that reimbursement parity is in place, and then making sure that there's access to broadband. So with that, I will stop. Happy to take questions or discuss.
Thank you so much, Mike, and thanks for your leadership in this area and for sharing your expertise on many of the steps that we tried to take. We have a big audience with a lot of people who have many different aspects of expertise, so even though I have questions, I'd love to hear from everybody else. Feel free to unmute yourself.
I can kick it off if that's okay. Thank you so much for sharing. I'm involved in our Bridge Clear Warm line here, so really excited to learn from what you've done. I was just wanting to ask a little bit about what strategies or kind of what you've used for engagement, like of these other treatment programs. You mentioned partnering with the harm reduction group, but I think one of the things that I know, at least here in Philly, sometimes some of the substance use treatment providers are not really on board with some of the more low barrier approaches. And it sounds like you're both connecting with and referring to those programs. And I'm just curious how you sort of navigated that and what you've found to be successful.
Yeah, I mean, it's going to be variable, right? Some places probably aren't going to be comfortable with that kind of approach. So really what I try to reinforce is we're not trying to replicate or replace their programs, and really just what we want, what our goal is with the best possible process would be you, meaning the treatment provider, the patient comes to you or gets to you somehow wanting help. We know that you're going to be doing a lot of different things, including trying to get them in very quickly. We also know that it's not reasonable, for the most part, for you to be able to see them the same day and start medication treatment. And so they have to buy into that ASAM approach. And I think the ASAM guidelines helped me as well to say, ASAM is on board with starting medication as soon as possible, even while still completing all of those level of care and engagement kind of assessments and things like that. So I think the groups that we've worked with are primarily COEs, centers of excellence around here. The harm reduction people obviously don't need any encouragement for low barrier care. But they really all bought in. I mean, I think they have concerns about diversion and if it were to be ongoing treatment that way, and I share some of those. And then it's just a philosophical question of what's the relative harm of untreated opioid use disorder and the relative harm of some diverted medication, which we know typically goes to treating opioid use disorder in an unsupervised way. That's not the goal, but when I weigh those risks and benefits and sort of make that pitch, I think a lot of people get more comfortable. But it's really a temporary nature that I think when we talk about DDAP or some of the more sort of establishment kinds of groups and SCAs, that they're comfortable with the temporizing nature of the clinic, at least how we do it.
That's great. I don't know if you can see the chat, but there are a couple good questions. Thanks, Krishna, for joining. Krishna White, Dr. White is a clinician in the Children's Hospital and looking at adolescent substance use disorder. So she asked, what was the age range of your patients, any adolescents or young adults?
Yeah, I mean, the youngest was 18. It's 18 to 74 was our age range. We don't, nobody's excluded. So anybody can be seen. I mean, I think that's part of our background as emergency docs is like, whatever, whoever it is, whatever you got, we'll take a crack, we'll do our best to take care of you. We just haven't gotten any referrals for adolescents. In general, treatment, particularly medication treatment, good evidence to support medication treatment for OUD in adolescents. But I do know that connection to ongoing care, it's critical for every patient, but really in particular for the adolescents. And we struggle with this at our Children's Hospital in Pittsburgh. We do start, treatments here, but we're very, very, very careful about making sure that all those connections are in place, even more so than with adults. And I would feel similarly here. I would suspect that if an adolescent got to us, it'd probably be in the context of a treatment program referring them, and that's really what I'd want to see. But we haven't had it. We wouldn't exclude them, but not so far.
That's great. Thanks. And thanks, Krishna, for joining. It's nice to see you. Judy Chertok is one of our family medicine and addiction medicine physicians, and she asked if you looked at a month or two later to see if patients are still engaged in treatment.
Yeah, great question. The short answer is not really, for a couple of reasons. One, we didn't start having a lot of patients until probably mid-year this past year. And two, I just haven't had the time. And part of it is because they aren't following up with us or necessarily even within our system. Navigating how to even access that data is difficult. So we're in the process within the UPMC health plan where we have access to some of that. But because so many are Medicaid or uninsured, even within Medicaid, the behavioral health MCO follow-up data I don't have access to. So that's why for the initial evaluation, I used medication fills as a surrogate marker, but that's short-term follow-up. So what I'm hoping to do is to gather all of our Medicaid patients, or as much as we can, and then work with Pitt School Public Health, which has access to Medicaid data for Pennsylvania, and really do a deep dive analysis on our patients and who they were and how they did, and ideally with a comparison group of similar patients with new diagnoses of OUD and how they did, to have a better idea of how well we did, essentially. So I don't have that data. It seems like the early trajectory has been good, but I don't know how well they've been retained in wherever they've gone to follow up.
That's great. And Shoshi, Dr. Aronowitz, I don't know if you want to unmute and ask your question, or you are in a place where I should ask it for you, but you could also share some of your experience as a Butte telehealth expert.
Sure, I have some laundry in the background, so sorry if it's a little noisy. Hi, thank you so much for this. This is really great to listen to. I was just curious because this is something that I have experienced in practice, and I'm starting to do a little qualitative research about issues that patients might have accessing buprenorphine at community-based pharmacies, assuming that you're sending scripts to community-based pharmacies. A lot of my patients, especially in rural areas in Pennsylvania, have had issues with pharmacies, and they seem part of what pharmacists seem to take issue with is the distance between the prescriber and the patient, which is what, of course, that's the point of telehealth. But I think pharmacists can be a little uneasy with that. So I was just curious if that's something that's come up for you. I think depending on where you are, there might only be like one or two pharmacies, and if the pharmacist won't dispense, then it's, the patient's in a hard spot.
Yeah, they would be, wouldn't they? We have really not had that scenario come up. I will say, the vast majority of our patients have been, sort of in the southwestern counties of Pennsylvania, but we've had Wayne, McCain, sort of northeast counties as well. And I have not gotten any feedback from any pharmacies or patients that they've had trouble. We have had some pharmacies where the patient says, send it to I ask them, where do you want me to send it? And they say, send it to this pharmacy. And I said, we send it to that pharmacy, and we get, call back. That pharmacy doesn't or won't carry or is out or something like that. And then we have to, they give us a different pharmacy and things like that. So, that's more a matter of stocking, but I have not had that experience. And the bigger, one of the bigger issues is getting it paid for, for our uninsured patients or those with coverage. Shouldn't be much of an issue, but getting it paid for has definitely come up, where some patients end up having to pay cash for their buprenorphine prescription because, again, I don't have a coupon program sort of anywhere they might go. There are a couple of pharmacies locally in Pittsburgh area that work with our harm reduction organization and mobile clinic to have that process. So I'll kind of refer my patients to the ones that I know have that and say, hey, why don't you go there and just tell them they sent you and get your meds. But otherwise, sometimes they have to pay cash, and we'll just have that discussion. I let them know up front that may be the case.
Thanks.
Cheaper than buying it on the street, I guess.
Great. And Dr. Delgado, if you want to unmute, or I can read your question.
I know, it's great talk. I'm wondering, I know with the limitations of people's phones, you're going to be limited to phone calls for their visits, but I'm wondering with the types of phones they have, is there the opportunity to text message them as a way of like staying engaged in between visits?
Yes, there is. I will say we don't really have the capacity to do that a lot. Usually, the way that I'll use text for them is after the phone call. I verify that they have a phone that they can receive text messages on and or access the internet via, if they get a link or something like that. And I'll use that as a way to make sure that they have referral options and things. So, I'll give them verbally, hey, these are the places you can go. Everybody has discharge instructions available to them via an app, but I know most of them probably don't go and access that. And then I make sure that they have information for follow-up. But as far as like motivational follow-up and more interventional kind of follow-up, there's absolutely that possibility. I will say my anecdotal experience is that a lot of patients, the phone that I'm speaking to them on is not theirs. They borrowed it from someone, or multiple patients on the same phone, and I'm sure many people on this call know it gets very sort of helter-skelter out there. I've talked to the same person on 4 different phones, at different times. So I think that part, and even with our warm handoff, we work with our warm handoff group, and I send them referrals for our patients to follow up with. They connect with them, and then the phone changes, and then a week later they call back on a different phone. Like, I lost that phone. This is my phone now. So all of those issues come up quite a bit. I do think that is, none of this stuff is 100% or perfect, and I'm a big fan of making sure that, perfect isn't the enemy of good, but I do think that would be an opportunity, something that we could be a low resource intensive way of maintaining engagement with patients.
That's a great summary there, Mike. That's what we think too. Yeah, it's like 4 minutes to 5, and this was a great hour of education. I guess I could put your email in the chat if anyone had any other questions, but I just want to really thank you for your guidance in the past 18 months and all of your tremendous energy putting all of this together for Western Pennsylvania. And hopefully there's a chance that we'll get another part of the state engaged in care in a similar way in the middle and the northern part with telehealth. But we are doing our best in southeastern Pennsylvania to model your care locally. So thank you for your time and everything that's gone up into this. And thanks everyone else for joining. That was great.
Thank you all. Thanks for having me.
Thanks. Take care. Bye-bye.